If you are practicing in the United States or in Canada for that matter, or Western Europe, and a lot of other places in this 21st century, you are going to run into a lot of patients who are overweight and obese, and I would say that the majority of the patients I run into at least would fall into the overweight category. They tend to be sicker, and the older you get, the easier it is to become more overweight because you're tired and your joints hurt. And so overweight and obesity is a big, big, big public health problem, at least in this country. So definitions. Overweight is a BMI of 25 to 30. And 35% of adult Americans are in the overweight range. So that's a little bit more than 1 in every 3 Americans are in that overweight range. Obese is defined as a BMI more than 30, and 30% of adults are obese. So when you put that together, 65% of Americans, the vast majority, almost 2 out of 3 Americans, are at least overweight. They weigh more than they should, be it overweight, obese, morbidly obese. And so this is a big deal. And this is a 300% increase between 1960 and 2000. So roughly in 1960, you had only about 20% of Americans were overweight or obese, and only about 10% of adult Americans were obese. So this is huge. For children, we do use the BMI, but we use it as a percentile in the percentile ranges, because the BMIs, the average BMIs, they change with as the child ages, and so we use the BMI, but then we plot it in the percentiles, and so overweight is defined not by a BMI number so much as it's defined by a BMI being between the 85th and 95th percentile, whereas obese for a child is defined as a BMI greater than the 95th percentile. And about 31% of children are overweight, and an additional 16% are obese. So almost half of America's children weigh too much. Risk factors for overweight and obesity. Well, of course, there's genetic predispositions, as far as like syndromes that you may have. But besides that, low socioeconomic status, probably what's behind that is that the access to food is not as good. And we don't have a problem in America so much as not being able to get food. It's that we have a problem of not being able to get healthy food. So if you look into some of these poorer areas in the inner city, their quote-unquote grocery store is really just a convenience store, and what they have there are soups with lots of sodium. They've got TV dinners. They've got fried foods. So lots of really, really not good foods for either children or adults. Race. I don't know if this is an independent contributor, but Black or Mexican Americans, those races also have a tendency in the U.S. to be part of those low socioeconomic statuses. But I'm not sure if this is correcting for that. Now, a thing you should also keep in mind is a person's tradition. If your family, let's say you come from a Mexican American family, and you have a grandma who likes to cook traditional Mexican food, and if that traditional Mexican food is fattening, well then you're at a higher risk, as opposed to, let's say you are Japanese and you eat usually sushi and rice and very lean food. So your culture can be behind it too. Parental obesity is another big one. Parents who are obese tend to they don't care what they eat. They a lot of times don't really care what their kids eat. Maternal education level, that's an interesting one. And then a history of intrauterine growth retardation. So children who were small at birth, really small at birth, they actually have a tendency to obesity. which you wouldn't think that. All right, so these are the growth charts. So remember, 85th to 95th percentile for weight is going to be that's down here actually. Is going to be the overweight range. 95th or plus is going to be the obese range. Here's another problem in this country. So if you look into the past, what did kids do to play? They would go outside and play soccer, or football, or run a race or ride bike. Now it's computers and TVs and more recently cell phones. Dinner time used to be almost always mom and dad or at least one parent at the table with kids having dinner. And when you eat at the dinner table with other people, you tend to eat slower because you're also talking. And that's a really good thing. It's always good to eat slower because it allows your brain to adjust and to secrete those hormones that say, I'm full. Whereas if you're eating by yourself or eating in front of a TV, you don't really get that. And this is exactly that. Note that these kids are not only eating in their living room with a TV, in front of a TV, but they're also eating takeout fast food. So here you see some of the problems that have led to those changes, that 300% increase. So the changes over the last several decades that have led to our obesity epidemic are in really all spheres of the food and how it gets to us and how we eat it, and then what we do when we're not eating. So production, the fast food industry, this is more and more common, a lot more common than it used to be. It's much more convenient than it used to be, more affordable, larger portions. They give larger portions. There's a high emphasis on fried food in the fast food industry. So you look at your big branches like McDonald's and Burger King, that's all sorts of fried food. They also give really large soda sizes. So like a 12-ounce soda, which is about a can, usually has about 150 or 160 calories in it. And a lot of these fast food places or even gas stations will give out these big gulps or these large, they have 30 ounces or even more. And so that would be 2.5 times what a can is. And so you're talking 350 calories just in your drink. Industrial foods, processing, they have less fiber, more simple carbs. Fiber will make you feel fuller, and so you'll eat less. The usage of high fructose corn syrup. Now, there's a lot of controversy about this, and there's a lot of commercials. I've seen commercials from the corn industry, and, corn farmers, bless their hearts, they have a really important job to provide us corn. But corn syrup is not good for you. And the reason, it's not because the commercial says, well, sugar in corn syrup is the same as sugar from cane sugar. And it's true calorie-wise, but high fructose corn syrup does not activate this melanoCoA pathway, and that pathway is helpful for reducing appetite. So you'll be eating this corn syrup, and if you were to be eating sugar, regular sugar, you would be activating a pathway to reduce appetite. But the corn syrup doesn't do that as effectively. So that's why you should stay away from high fructose corn syrup. Consumption, of course, mentioned larger portion sizes. Calorie-dense food is much more readily available and cheaper. Then there's also marketing pressure. So you turn on the TV at 4 or 5 o'clock in the evening, you're going to get bombarded with commercials from restaurants. Activity. So, of course, we have a more sedentary lifestyle. We rely more on cars and buses than we do on walking and biking. Our entertainment comes more from TVs, computers, and video games, whereas in the past, we might have walked to our neighbors' houses, taken a walk, walked somewhere into town, or went outside. And then also, and this is a big one, more sleep deprivation. So this results in a lower glucose tolerance and an increased cortisol. There's also an increased ghrelin, which is a hunger hormone, and a decreased leptin, and leptin is sort of the opposite. That's a satiety hormone. So when I started medical school, I gained 15 pounds, and I know darn well it wasn't from what I was eating. It was stress. Okay, you don't eat a whole lot when you're working in the hospital. All right, so some causes of obesity. Of course, there's idiopathic and lifestyle, and that makes up the vast majority of them. But you also have to keep in mind some of the underlying medical conditions that may be there. And the number one that always comes to mind when you have a patient who's overweight, especially if it's just slightly overweight, and they say, I've been dieting and I've been exercising and I'm still overweight. Okay, well, maybe you are hypothyroid, so you get a thyroid level. And some other things that hypothyroidism would show would be like fatigue and dry skin, intolerance to cold, constipation. There's also hypercortisolism. Now, these patients are usually a little bit more obvious because they get that moon facies and striae in hair, and they also have a high blood pressure, some edema, and if you get a BMP, they'll have a low potassium or a low normal potassium. So here we're thinking of things like Cushing's disease. Hyperinsulinism, it's pretty rare. You can get an insulin-secreting tumor. In children, it could be an acidoblastosis, but usually that'll present as itself long before the obesity. This is just a high serum insulin. And then growth hormone deficiency, you see, of course, short stature. And again, that's usually, that'll usually be diagnosed before the obesity, I would think. So then Down syndrome, and most of these will be diagnosed before the obesity. So Down syndrome, they have abnormal facies, mental retardation, short stature. Turner syndrome, they have the webbed neck, short stature, amenorrhea, low set ears. Prader-Willi syndrome, they have unique facies, so they have a very thin upper lip, a prominent nose, a narrow, tall forehead, and they also tend to have a lower IQ. These kids have a really big appetite. Bardet-Biedl syndrome, they have a lot of ophtho issues. They can get retinitis pigmentosa. They can have some issues with their iris. They also have problems in their extremities, polydactyly or syndactyly. And then there's another one, really, really rare, POMC deficiency. You can look that one up if you want. I think it's pro-opiomelanocortin, something like that. I don't know. So comorbidities of overweight and obese. You probably know these, but let's look particularly in children. So boys who are overweight or obese in adolescence are twice as likely to die from cardiovascular disease as when they become adults compared to their normal weight peers. So if you take a group of 15-year-old boys and girls who are overweight, or actually no, it's just boys. So 15-year-old group of 15-year-old boys who are overweight, and a group of 15-year-old boys who are normal. That group who are overweight, when they hit their 50-year class reunion, 50 years later, half of those boys in the overweight group will be around because of cardiovascular disease. They also have an increased incidence of non-alcoholic fatty liver disease. This is something usually you see in obese adults, but it's increasingly prevalent in children. This ultimately will lead to cirrhosis if it's not corrected. Metabolic syndrome, you know that. That's just a quartet of symptoms. Obesity, hypertension, glucose intolerance, and hyperlipidemia. Type 2 diabetes, of course. This is something that you only used to see in obese adults. Now, sadly, we're starting to see it in obese kids. Orthopedic issues, Blount's disease, which is a problem of the tibia, where the growth plate sort of collapses under the weight, and it causes the tibia to bow forward or to the side. Then there's SCFE, which you know is the dislodgement of the epiphyseal growth plate in the hip. Gynecologically, in older, not older women, older girls and women, you can see polycystic ovarian syndrome. That's obesity. You get a little bit of extra hair growth, extra androgens. Then they can have unusual cycles, unpredictable menstrual cycles. And then psychiatric, of course, self-esteem issues. They're at risk for major depressive disorder, and they're at risk for ultimately developing eating disorders. So when you evaluate these patients, when you have children there, if you're evaluating a child, it's ideal to have both caretakers present because you want to get a good idea of sort of how this family unit is functioning. But if you're dealing with an adult, then you can just deal with the adult on their own. So you want to have vitals, where we're looking for possible hypertension, and of course you need to chart your growth. Then we look at the patient's history. So, what are the kids' eating habits and patterns? Are they eating in front of the TV? What are the preferred foods? How much and how often does the family eat fast food? How much fruits and vegetables are they eating? How much pop, sweetened beverages, soda? We say pop here in Minnesota, but soda. So, drinking 1 can a day, 3 cans a day. When I was little, I think I used to drink 3 or 4 cans a day. I think when I was in high school, that wasn't good. Daily routine and exercise. Do they go outside? Do they exercise? Do they have a gym class at school? Are they involved in extracurriculars? And then how often is the kid on the computer or watching TV? And that's a big one now because uh, it's not uncommon for 4, 5, 6 hours of TV exposure per day. And that time, 50 years ago, would have been time spending outside playing. Also, what are the sleep patterns? So this is important, not just because sleep can cause obesity, but lack of sleep can cause obesity, but obesity can cause sleep issues. So how many hours per night is the child sleeping? Remember that children need more than 8 hours of sleep compared to adults. Is the child snoring, or does that child have daytime sleepiness? Family history, so is there obesity in other relatives? And then you want to ask if there is, are there any comorbidities like type 2 diabetes? What about any medications the child is on? Atypical antipsychotics, not very common. You see that in kids. And then steroids, they promote weight gain. Physical exam, you assess for comorbidities. So we're going to look at acanthosis nigricans. That's an early sign of type 2 diabetes. Look at the hip or the knee. If there's pain there, that can suggest Skiffy or Blount's disease. Usually the child will come in complaining about the hip or knee before they come in for their well child visit and there's obesity. Usually Skiffy or Blount's will present on its own. Abdominal pain suggests non-alcoholic fatty liver disease. Of course, irregular menses and hirsutism suggests polycystic ovarian syndrome. So this is acanthosis nigricans, just a patch of darkened, pigmented skin. It looks the same in children and adults for the most part. And it comes up on the back of the neck most of the time. You can also see it here in the armpit. So here's Skiffy. You have the separation of the growth plate on the hip. Blount's disease, you see some bowing here, and that's just due to the weight and the pressure on the growth plate. This is polycystic ovarian syndrome, so usually when you look at an ovary, you should only see like maybe one cyst, but here you see lots of them. And so in addition to seeing this, and the sonography is really your confirmational test for polycystic ovarian syndrome, but it's a diagnosis that's made, of course, like most, in a context. So you have a woman with irregular menses, and she's overweight, and she's got abnormal hair growth. So that together makes up polycystic ovarian syndrome. And usually the treatment for this is contraceptives. Obstructive sleep apnea is something you see in any obese person. Most obese people will have some degree of obstructive sleep apnea. So in this case, what happens is the mouth will open while sleeping because they need to get air in that way. The tongue collapses in the back of the throat rather than being in its normal position. The airway then becomes blocked and breathing becomes turbulent. And that's what causes the snoring. And so you may sleep, or the child might sleep 9 or 10 hours, but if they're in obstructive sleep apnea, they're only going to get the quality of sleep that might be like 5 or 6 hours. So they're going to be sleepy during the day. And you can see how the problem this causes is that if you have a child who's obese or overweight, and then they have OSA, and they're not breathing, and then they're tired during the day, what are they going to want to do when they get home? They're going to want to watch TV and maybe eat. They're not going to want to go outside, play football, play with neighbors. So this can cause a vicious cycle. So this is always something you should think of if you have an overweight or obese child who also is known to be a snorer and daytime sleepiness. And the treatment for this is CPAP. CPAP is just a machine that provides concentrated oxygen, and this is really useful for these kids. It prevents the airway from closing, and they go through the night getting good oxygenated sleep. BiPAP is another way that it can be done, but these machines they're rather affordable, and they can be brought home. They're pretty easy to use, and it'll make a big difference. So, okay, so overweight and obesity, how do we work this up? We're going to get a BMP, we're going to get thyroid function tests, we want a lipid panel, and then if they have a family history of type 2 diabetes, then we're going to get a fasting plasma glucose and work that up, because it is possible that a child can develop type 2 diabetes, and so we do need to be concerned about that. But at the very minimum, we need to get a metabolic profile, we want to get a lipid panel, and of course we want to check, some cases it is hypothyroidism, so we want to just make sure. Other labs that you can get based on findings, so if there's daytime sleepiness or snoring, you can get a sleep study for obstructive sleep apnea. If there's hip or knee pain, you can get radiographs. If there's irregular menses and hirsutism, you get pelvic sonography. If there's a high sodium or low potassium, you can get a dexamethasone suppression test looking for possibly Cushing's syndrome. Management is going to, when it's children, it's got to involve the whole family, because a lot of children don't get to make their own meals. So family education, dietary advice, pretty easy advice. You should be able to provide most of this. So meals based on fruits and veggies, lean meat, fish, poultry, and whole grains. Drink more water. Sweetened beverages like pop, soda, I don't really have a problem with them per se, but they should be considered a food product, not something to quench your thirst. So if you really, really like your Coca-Cola, and you want to have, you can't go a day without it, well, that's fine. You can have one Coca-Cola a day, but that's going to be like in place of having a dessert, a small dessert, or a bowl of ice cream or something like that. It needs to be considered a food product, not something that you drink because you're thirsty. You need to take a gradual approach based on individual behavior. Remember that this is a lifestyle change, so just making a drastic change is not really going to lead to any good long-term results. You can also refer these patients to a dietitian or nutritionist. That's probably even better. They can give you more advice than you can. Of course, you need to increase physical activity. The American Academy of Pediatrics recommends no more than 2 hours of TV or computer activity per day. I would definitely fail them. Be aware of low-cost or after-school recreational activities that you can recommend to children in the local area. So this is especially if you're a family practitioner and you're working in a community. Be aware of different things that are going on that the child can get engaged in, and a lot of these things are low cost, or they can get vouchers through the school systems. And then special populations, adolescents, you can consider the use of some of these diet drugs as long as it's in conjunction with diet and exercise. So I would say probably 14 or 15 or older. The younger they are, the more concerning it would be to use them. So adolescents, I don't know. I probably wouldn't use it in anybody under 16. If it's younger than that, you might want to check the label on the medication. But you can use these as long as it's in conjunction with diet and exercise. So sibutramine is, I believe, a serotonin and norepinephrine reuptake inhibitor. Orlistat is a pancreatic lipase inhibitor, and so this will actually block fat from being absorbed, but not without some really nasty side effects, which are pretty much flatulence, bloating, diarrhea. Bariatric surgery is only indicated if the patient is skeletally mature, so pretty much you're only going to be doing these in adults, and they have a BMI of greater than 40, which is considered morbidly obese. Referral for comorbid conditions should be done if necessary.